Hey guys, welcome to your Seclusion Induction. My name is Jack. I am a Senior Healthcare Support Worker on Maple Ward, so that's the PQ over there. I'm also a PMBA instructor. Could I just get some introductions from you guys as we start here?
My name's Alfie and I've just joined the tracks and I'm new to the role.
Cool, nice to meet you, Alfie.
Yeah, my name's Jess and I've never done anything come to that place.
And you both support workers?
Yes.
Yeah.
Cool, okay. So how this is going to work is we're just going to do sort of our presentation. We will have a break in the middle. I will sort of feedback sort of questions and stuff like that throughout as well. Yeah? Cool. Let's get started then. So, fire evacuation points. We're not expecting a fire drill today, but so if the alarm goes off, we'll treat it as a real thing. You're just going to exit out the way you came, through to reception. The assembly point is out in the car park, or we can just go straight out this door if that's blocked for any reason, straight up into the outside. We can then access the outside from there. Ground rules. So this is a non-smoking hospital. Like I said, we will have a break in the middle. So if you need to go off and have a cigarette, that's fine. Just do it off the hospital grounds. Refreshments. Just keep the area tidy. Obviously, we've got some provided for you, so that's fine. But please just keep that area tidy. Phones away. Obviously, this is adult learning. If you need to make a phone call or for whatever reason, that's absolutely fine. But just while we're doing the presentation, if I can just make sure you're paying attention just by keeping your phones in your bag, that's absolutely fine. You don't need to turn them off. Just pop them on silent or vibrate. Show respect to others. Obviously, everyone's opinion needs to be respected. So just make sure we're mindful of that throughout the course. And then if in doubt, please ask. So basically any questions you have, please ask. Obviously you guys have different levels of experience. Some of you have been on the ward more than others. So that hopefully you can kind of fill in each other's gaps in knowledge as well. So just ask as many questions as you can. Yeah? Happy with that?
Yeah.
Cool. Learning objectives then. So the first learning objective is to understand what seclusion is. Then we're going to understand when seclusion might be used. We're going to understand your responsibilities once seclusion has been initiated. And then we're going to understand when seclusion should be terminated. Okay? Cool. Any questions so far?
No.
No.
Cool. So, what is seclusion? So the Mental Health Act Code of Practice defines seclusion as the supervised confinement and isolation of a patient away from other patients in an area from which the patient is prevented from leaving. Okay? So confined and isolated away from other patients in an area where the patient cannot leave. If we think about that definition there, if we took one of our patients on the ward and we put them in their bed space, so they're on their own, we shut that door and we locked the door so that they then could not get out, do you think that would constitute seclusion based on this definition?
Yes, maybe.
Maybe?
Yeah.
Yeah. If we think about the parts of this definition, confinement and isolation of a patient, so we've confined that person, we've isolated them, we've taken them away from other patients, so they're in their bed space, away from the general population on the ward, in an area from which the patient is prevented from leaving. Yeah, we've locked the door, we've stopped them from leaving that area. Yeah, so you could say that constitutes seclusion. So we need to be really mindful about our practice so that we're not secluding people when we shouldn't be. Does that make sense? Cool. Seclusion should only be undertaken in a room or suite of rooms that have been specifically designed and designated for the purposes of seclusion and serve no other function on the ward. Okay? So, have you guys both been over to Maples?
Not yet.
You've not, you've been on Maples. So we have our seclusion suite down on Maples. That picture is the corridor on the seclusion suite. So the doors just behind where this picture has been taken, those doors will remain shut. So patients can't just access that area. As soon as you go down that area, you've got doors to the right and left. They're leading to our seclusion rooms. That is our seclusion suite. So that is where we should be secluding people because they are specifically designed for seclusion. Does that make sense?
Yeah.
Cool. Any questions about that?
No.
When to use seclusion then? So the purpose of seclusion is to contain severely disturbed behaviour which is likely to cause harm to others. Yeah? Harm to others could be physical or it could be psychological. So could you guys give me some examples of what that might be? What might be physical, what might be psychological?
A scratch.
A scratch, yeah, that could be physical harm.
Mm.
Anything else?
Maybe like telling someone you're gonna beat them up every 5 minutes.
Yeah, so threatening people, yeah, that would probably constitute psychological harm, yeah. So we could have all manner of physical harm, basically anything you could think of, any way that you could assault someone, punching, kicking, scratching, all those sorts of things. But then you've got psychological harm as well, yeah, where you've got sort of threats to others, maybe harassing other patients on the ward. You could think about using seclusion in those instances as well. Always use the least restrictive option. So we are not jumping straight into seclusion. So you gave the example of the scratch. We're not likely to seclude somebody just because they've scratched someone. It's going to be, kind of a last resort, because, locking somebody in a room on their own is going to be our most restrictive option, and we always want to be working to the least restrictive option. So what sort of things do you think we could be doing before we get to seclusion? You guys have obviously been on the wards a little bit now. Can you think of anything we might be doing to manage behaviour before jumping straight to seclusion?
Let them out in the garden.
Let them out in the garden, yeah, fresh air, sort of distraction, external spaces, definitely. What else?
Asking them what's wrong.
Yeah, just talking to them, engaging with them. Yeah, one-to-one time. Anything else?
Can they have that extra meds maybe?
Extra meds, yeah, so some of our patients will ask for extra medication. We might think about offering that as well, particularly if we're seeing those signs of distress. So yeah, you guys have got a few of them there. So we said one-to-one time, level of observations, yeah, so particularly on the peak, all of our patients on 15-minute observations. We could look at controlling that, yeah, so we could increase the observations, maybe put a staff member on a one-to-one or a two-to-one, particularly if they're violent and aggressive. PRN, so that's obviously the medication we spoke about, and then you've got rapid tranquilization as well. Yeah, so we could think about using that. And all of those options would be preferable to placing somebody in seclusion. So really we should be evidencing that we've tried these sorts of things before jumping straight to seclusion. You will have some situations where the risk is so high that we need to move straight to seclusion, but otherwise we want to be looking to manage these people on the ward using these sorts of techniques. Does that make sense?
Mm-hmm.
Cool. Any questions about that?
No, I don't think so.
Cool. Types of seclusion then. So seclusion suite consists of two distinct areas: tertiary seclusion and secondary seclusion. Does anyone know what tertiary seclusion is?
No.
Is that when you're in the room with them?
Not quite. Good guess. It's not quite. So you'd be thinking of secondary seclusion.
Oh.
Yeah? Cool. So tertiary seclusion, patient only has access to a bedroom, bathroom facilities and lounge area. They are isolated in this room and have no access to staff. Yeah, so that's just a slight difference. Obviously in secondary seclusion they would have access to staff. Tertiary seclusion, they have no access to staff, so staff will not be in that room with them. Staff continually observing from outside the room. Yeah, so when we say no access to staff there, they do have access in terms of they can talk to staff, because there's always going to be staff outside the room. They will be engaging with staff in terms of staff will be giving them items through the hatches, but they'll have no physical access to staff. Staff won't be inside that room with them. Yeah.
Mm-hmm.
It says bedroom, bathroom facilities, lounge area there. Essentially it is all one room amalgamated into one. I have got some pictures in a minute, so we'll actually show you what the room looks like. Cool. Secondary seclusion then. So you kind of touched on it there, Alfie. Patient has access to a bedroom, bathroom facilities, lounge and garden area. Staff are present in the room with them. Yeah, so there'll always be a minimum of 2 staff members inside that room. Might be more depending on the risk. And it's a slightly bigger area, so there's kind of 2 slightly separate rooms which the patient can walk between, and then they have access to outside area as well, so garden space.